So we have, as Bree mentioned, a not to be missed panel. And so I'm gonna just give a little bit of orientation. So each of our panelists is going to give about a 1 minute or so intro. And then we have some questions that we sort of drafted to help kind of generate some discussion. And so we'll be asking questions to each of our panelists and give everybody an opportunity to speak. And then hopefully we'll have a little bit of time at the end for some Q&A for additional questions that folks may have. So our panel, Lauren Brinkley-Rubinstein, Michele DiThomas, Fernando Murillo, and Jennifer James. And again, I'm gonna let each of them give a short 1 minute presentation about themselves and what their interests are. And then we'll kind of go into the questions. And we've already forewarned them that Sarah's gonna be a strict timekeeper. So I'm gonna just go ahead and start in random order. So Lauren, would you like to go first?
Sure, thanks, Nick. I'm really happy to be here and to see all of your faces on the screen. I'm Lauren. I'm a faculty member at the University of North Carolina at Chapel Hill, and am trained as a community psychologist, which is really how my brain works. So think about incarceration using the social ecological model and the impact of the criminal legal system on communities, families, individuals. Have done a lot of research sort of at the individual level, thinking about conditions of confinement, and then also more recently have started to think about the population level impact of mass incarceration in particular. Last March, Catherine, who's here, and I started the COVID Prison Project. So we've been doing mostly COVID related work over the last 15 months or so. And we also are doing the only NIH Radix funded COVID grant in correctional or carceral settings. And so trying to get testing and other mitigation strategies behind the walls in 12 facilities across the country. And yep, I think that's great. Thanks for having me, guys.
Thanks, Lauren. Michele DiThomas, would you like to go next?
Sure. Thank you so much for having me, and thank you all for being here. I am the Chief Medical Executive at the California Medical Facility, which is a prison in Vacaville. I'll just share my route to this job briefly. I was a medical student and resident at UCSF. I trained in the family medicine program, which has a mission to work with an urban underserved population. And I had a lot of experience with my patients who were struggling with substance use disorder, with mental illness, with intermittent incarceration, and I became really compelled by their stories. So when the receiver took over medical care for the state of California because of the unconstitutionally poor care that was being provided, I went in as a consultant through UCSF, and it's very compelling. And there's reasons I think that we'll talk about more on the panel about why to be inside. I think we need people on both the inside and the outside working for change. So,
thank you, Michele. Fernando, would you like to go next?
Sure. Thank you guys for having me. I'm happy to be here. My name is Fernando Morillo. I worked in 6 years in the California Medical Hospice, which is the only licensed hospice in the state of California prison system. I was formerly incarcerated for 24 years. I received a life sentence at the age of 16, and I was had my sentence commuted by Governor Gavin Newsom November 20th, 2020, which was, like I mentioned before, my 24th year in prison. I got involved in the Robert Evans Alexander Hospice Program because I seen the need of compassionate end-of-life palliative care that was offered to my peers in the correctional setting that were dying from terminal illnesses. I was really inspired by the many people that were part of the program that were committed to providing end-of-life palliative care to our peers. And we functioned with a motto back there that said nobody would die here alone. And I took that very seriously, being personally available to somebody that was otherwise lonely and felt isolated and anonymous in an environment in which, it's culturally acceptable to dehumanize so many of us. So we took the time out to carve out a small little space to humanize people and to provide them a sense of normalization in an environment in which normalization was not really present in the overall construct of prison. So yeah, so I work for the University of San Francisco now. I'm a part of AMEND. I work with the team of Dr. Bree Williams, and I formerly worked with Dr. DiThomas. And I'm anxious to see how this panel goes today. I'm a little nervous, but it's good to see you guys.
That's okay. Great. You're doing great. Thank you, Fernando. Jennifer, last but not least, go ahead.
Definitely feels like least. I'm so excited to learn from everybody else on the panel, so I'm glad I get to have a microphone to ask questions of my own. I'm Jen James. I'm a sociologist. I'm an assistant professor at the University of California, San Francisco in the Institute for Health and Aging and the Bioethics program. I'm a qualitative researcher. My work focuses on experiences of health and illness and aging for currently and formerly incarcerated women. And I'm really passionate about research that's community engaged, community-based, community-driven, and I do work in partnership with several community organizations that work with incarcerated women. And I'm really right now trying to find ways to do more work that's in partnership with people who are currently incarcerated to really figure out what their needs are and the best ways to address them. So I'm excited to be here.
All right, wonderful. So obviously, as everyone can tell, our panel has a wealth of expertise. And so I'm going to jump into some of the questions, and I'll sort of kind of direct these at folks just as they indicated some of the questions they'd like to respond to. So I want to start off with the first question. We saw from Bree's fantastic presentation earlier, just in terms of the huge increases in the population of folks in prison over 55. So I want to talk a little bit about the power of partnerships between researchers and correctional agencies to address the needs of aging among prison populations. So to speak to the partnerships between researchers and correctional folks, I wanted to first turn to Lauren, and then Fernando, I wanted to follow up with you. But Lauren, can you tell us a little bit about sort of your experience in forging and developing partnerships between corrections and community?
Sure, thanks, Nick. Yeah, so I think, I have a perspective on this that is like kind of before COVID times and after COVID times, and what those partnerships looked like in the context of COVID really changed, and some of the hard decisions around partnership and what that looks like changed during the pandemic as well. My lab and the folks that do work in collaboration with me have had good partnerships with a number of different systems. And I think, this probably comes as no surprise to most of you. It's kind of a tough balance to walk sometimes, right? Because we need to get in the door to do the research that illuminates much of what is happening, but you have to, stay in partnership with folks who give you that access. So it's this balancing act that can be very difficult. The example I'd like to really talk about is, I think a really important paper that looked at solitary confinement and the impact of solitary confinement on mortality post-release, which I think has been very important in the movement to end solitary confinement, and is really the only paper that looks at the impact of post-release death. And what we found was that any moment of time spent in solitary confinement is associated with a higher risk of death in the first year post-release. And we had to get those data from the Department of Public Safety here in North Carolina, right? So we had to work with them to give us this data that they knew was going to not make them look good. And so we worked in collaboration with them. Thank you, Sarah. Time warning. We worked in collaboration with them. We gave them findings. We presented it to them. We talked through what the implications might be, and we included them as authors on that paper. And so I think that serves as a nice example of how to do really important work that moves the needle on important policy in collaboration with system partners.
Thanks, Lauren. Yeah, that's a great example. And Fernando, from your perspective, from being on the inside, how do you see sort of research partnerships with correctional entities? Where do you see the importance of those and how those can really help to improve health among folks who are aging in correctional systems?
Yeah, so these partnerships are extremely important. one of the most challenging circumstances that we had in the hospice was getting some of these guys that have been diagnosed with terminal illnesses out of the door for compassionate releases and medical releases. So many of them would be approved, but it would have nowhere to go. So having these community partnerships and research, providing statistics about the amount of people that have been approved for medical parole and compassionate releases and just really had nowhere to go is extremely important, because it'll help us continue developing further partnerships with places that we collaborated with to parole people. To we had a place in Pacifica in which we were paroling hospice patients to, which were some nuns at the sister's house. And that was just one of a few places that we can actually parole people. If we can expand the role of community partnerships and get more folks involved in allowing some of these guys to parole in their nursing homes and their end-of-life care facilities in the community, it'd be extremely helpful. There'd be so much more hope for these guys to actually parole to the community as opposed to dying in the carceral setting. And that's just something that's extremely important for us to partner with, just so we can stop the morbid amount of people that are passing away in a carceral setting just because they don't have any more resources in the community, because it was never a plan for somebody to reintegrate back into the community after incarceration or conviction. So,
all right, thank you. Michele, I want to kind of ask you from your perspective as somebody who is on the inside providing care. What is your perspective in terms of how necessary it is to push the boundaries, so to speak, and providing care for folks who you see as patients in an incarcerating setting? So you heard the example from Lauren in terms of, sometimes making those sort of policy advocacy positions, taking those kind of positions could provide some tension. So from your perspective, what do you think about pushing the boundaries? How hard can you push from the inside, and how do you really get to the point where you can actually improve the care for folks?
Yeah, so I mentioned, I have a lot of ethical conflict with where I work at times, and so part of balancing the stress that comes from working at a place that clearly has values that are very different than mine, and we could even say has pretty significant human rights violations, is working on culture change from the inside. So I think part of what I've done the whole time is try to work together to push the boundaries, but in ways that allows the security side to see that what we're doing doesn't impede their actions. So for example, we had a patient in hospice who was dying, and all he wanted to do before he died was to say goodbye to his daughter. But she was incarcerated in a prison in Southern California and was actually in a psychiatric administrative segregation, so solitary confinement. So normally that wouldn't be a call that would be allowed. But our warden is used to us sort of pushing the boundaries in our hospice setting. And he said, well, I'll ask the other warden. So he asked the other warden, they gave permission, they set up, arranged for them to have a phone call. And after the phone call, they put together her psychiatric team to give her grief support. And all of that was great that our patient got that. But the biggest benefit was at the end, we got an email back from one of the captains who had been assigned to arrange this at the other facility. And he talked about how in 25 years of service, this was one of the most rewarding things that he'd been able to participate in. So, to me, now that other institution has somebody who sees that we can treat people humanely and still have safety and security. In fact, I would argue gives you greater safety and security because you've created a relationship and you've shown people that you're going to respect them. I can think of so many other examples of sort of pushing the boundaries. I can think of an example where an officer, I was treating a transgender woman for skin condition. The officer, I said, make sure that she does something when she gets back. And she's like, this is a men's prison, and was pretty aggressive and seemed angry. And I just, stopped, and it feels almost like there's going to be a conflict here, but I just posed some questions, presented the reasons that I felt it was important to use the pronouns she was comfortable with. And the officer left within a half an hour, she called me from the unit and said, I didn't catch what you wanted her to blah, blah, blah. And she used the right pronoun. And that was at the very beginning of my work. And I realized that, you know, it's not always as hard to change people. Sometimes they just haven't really thought about it. So I think in terms of research is going in and sort of having a positive attitude, assume good intent, assume maybe it's a lack of education, and that when you provide additional information, you may have some really great partners on the inside who may not see things exactly the way you do, but may also have a goal of improving conditions.
It sort of reminds me of some of what Fernando was saying in terms of just also recognizing humanity in other people.
Yeah.
And so I want to give Jennifer a chance, and I want to just piggyback on some of what Michelle was saying around changing minds, and sometimes it's difficult, sometimes it's not so difficult. So what is a misconception that you hear, Jennifer, and the work that you do, a misconception you hear about correctional staff as a researcher, and as you're thinking about partnering, you know, oh, correctional staff or A, B, C, you know, what are some of those things that you hear, and how do you respond to some of that?
Yeah, no, that's a great question. And I definitely, doing work with people who are formerly incarcerated and currently incarcerated, I hear a lot of not great things about correctional staff. And I think something I hear often, and I want to say specifically about healthcare providers, is I think there's an impression that people who work in correctional health, it's because they can't work anywhere else, right? It's the people who nobody else wants them, which is heartbreaking. And I also know that this isn't true, right? There's people on this call who demonstrate that this isn't true. They're there because they want to work with this population who hasn't gotten good care in the past, who hasn't had access before. And so I think that's something that's so important. And I also, while I'm on that, we'll just put in a plug that I am trying to do a few more interviews with correctional health folks about working inside during COVID. So if that's you or you know people, please let me know, because I think we do need to think about what it's like and all the challenges that come from working in this really difficult environment. And what I think is important, and I think this speaks to work that Amen does as well, is how we think critically about individual corrections staff and correctional institutions as a whole. And I think corrections is just like any other field, right? There's all kinds of people who work there, who go and work there for all kinds of reasons. But what I hear a lot is that people don't trust the institutions, even though they have individual, either healthcare providers or correctional staff that they maybe have close relationships with, that they work well with, that they trust. They don't always believe that the institution has their best interest at the forefront of what they are doing, which I think makes it hard to enact change. It makes it hard for people to trust in the healthcare they're getting. So I think thinking about what are the ways that we can look at the entire culture, how can we really interrogate the forms of oppression upon which these systems have been built to sort of allow individuals, as Michelle was saying, to learn and grow and work compassionately with people within this system that we know is difficult and troubling.
Thanks. And Fernando, I want to also pitch that question to you as someone on the inside who's obviously had a lot of interaction with correctional staff. What are some maybe misconceptions that folks may have that, and maybe some of what you hear is accurate, but maybe some of it is not so accurate, or things that you were surprised by in terms of your relationship and interaction with correctional folks during your period of incarceration?
Yeah, so thank you for asking this question. I'm so excited about answering it. There's such a big misconception that there's this universal application that all officers are bad. They're just notoriously inherently bad people, which is not correct at all. So many of the people that I met that left the academy were conditioned to feel a certain way about myself, that I was the enemy, that I was the us versus them. But as time went on, when a lot of these correction officers would leave the academy, their conditioning would slowly erode, and their consciousness would weigh heavily on them, because they can feel the humanity within myself, the relatability in people like myself. They can see so much of their youth in people like myself, the relatable experiences that we once had, and they see the remarkable things that we do despite the challenges that we had during our incarceration. And some of them come up to people like me, will put their hand on my shoulder and say, "Hey man, you're a good guy." Or they reach their hand out and shake my hand and be like, "I hope that you get out soon." There's many correctional officers that be invested in the individual resident that is in the process of reclaiming their freedom, to support them in that role of reintegrating back into the community. And it is profound to see how these individuals would take the time out to humanize people like me, despite the officer culture of people wanting them to feel like the general officer culture and dehumanizing us and creating the continuing to function with the us versus them culture. And it was wonderful to see and refreshing to see so many of these correctional officers that wouldn't function that way, that wouldn't dehumanize people just for the sake of their profession. So that is a profound misconception that there's just like this universal umbrella of officers that just don't care. There's a lot that do care. And it's wonderful to see. And I wish people could see more of that, because they put themselves in harm's way by humanizing people like myself.
Thank you for that, Fernando. I want to keep on the theme of sort of interaction, staff interaction and relationships. And I wanted to ask Michele, how complicated are the day-to-day relationships between healthcare staff and correctional staff? So somebody that provides care, what does that dynamic look like? How is that for you? What are some of the challenges that you face, and how do you work with those or work around those challenges?
So, I can only speak from my experience, which has actually been, well, I've had 15 years to develop the relationships. I think it's a little different when you're going in as a researcher. But, you have to find your allies. As Fernando was saying, there are people on the inside who want change, who want to make it better, and who are very open to these sorts of programs. So in my experience, I assume good intent. I work really hard to develop relationships. So when I have a problem, I know who to go to and who can help me achieve the goals that we need for our patients. I try to be open and approachable. I want an officer who sees an older person who may not be navigating the stairs well to call me. I don't want them to not feel that I'm somebody who will assist. And it happens all the time. I have officers multiple times a week will call me because they're worried about the health of an individual that's under their supervision. So I think it's really important to keep that dialogue open. We have the people who have cognitive impairment. There's special units where we house them because they were just being left in their cells. They wouldn't shower, they wouldn't dress, they wouldn't brush their teeth because of their developmental disabilities. So now there was a lawsuit, Clark, and so they're all housed in areas where they have special Clark officers who are supposed to provide additional support and prevent these men from being, and women from being victimized. So these Clark officers are sometimes really incredible. They know these people so well and they care for them. They're a great resource. So when you have a patient, using them as a resource, because they can tell me things, I think I know the solution to this man's problem. But when I spend time talking to the Clark officer and bringing them as part of the team, I may end up with a completely different treatment plan. I've had healthcare staff come in and be like, oh, this demented old guy can't be here. He has to be in the hospital unit. And then put stuff in, had them move without talking to custody. And that man sat on the floor with his bags packed for 3 weeks. I sat on the floor for 45 minutes with him, trying to let him know that we're here to help him. He just wanted to go back to his other unit. And even though it wasn't necessarily the place that medically I would have wanted him, it was the place he needed to be. And he actually had the support because there was a team of officers and mental health staff that knew him and supported him. So I think I may have diverted from the question, but I think getting to know who the people are that you can trust and really accepting them as advocates who can help you makes a big difference. I think I might be over, so I'll stop.
No, I think you answered the question perfectly. I mean, in terms of the different levels of relationships that folks have with different staff. So thank you. Lauren, I wanted to kind of go back to you to some of what you were describing before in terms of the data around solitary, and it kind of ties into a question we had around some of the pitfalls in terms of correctional healthcare professionals and just correctional staff partnering with researchers. And so, how do you address some of these thorny issues where, as a researcher, you're wanting to ask a certain question or get certain data that may be very sensitive to a Department of Corrections or a jail or whatever. So how do you navigate that?
Yeah, it's a hard question to answer because I think there's it's hard to do. If we go back to the solitary example, it only happened because there was a lot of trust between the research team and correctional staff, and there was a long history of partnership in which we had sort of done right by each other. And so I think, that's a hard thing about research in this field in general, is the amount of time that it takes to often get access to, prisons and jails. And I think that research project in particular benefited from this long history. And I think that's why, unfortunately, in some ways, we see a lot of the research come out of the same places over and over. I'm like thinking about Rhode Island, which I feel like I can talk about because I lived there. But like Rhode Island's such a weird little state with a very different prison jail situation. And, like some of the, most groundbreaking work over the years has come out of there because of this 30-year history of research. But in some ways, it's not very generalizable to the rest of the places that we work. And so it speaks to this long history that's needed and this reciprocity. I think the other thing is really around communication. And so we didn't just go to publication with that paper. We provided interim results. We talked through it. They were surprisingly surprised that the results looked the way they did, and we had to talk them through it. And we did that, and they came to a place where they understood it, and they understood what the repercussions might be, and who was going to handle what, and it worked out. But it takes a long time. And so I think that's kind of the theme here, is that it takes a lot of time and persistence to do this work.
And Jennifer, I wanted to follow up with you the same question in terms of somebody sort of, and I know you're kind of early on in your career and relationship building, but what are some of the things early on that you sort of sensed of some challenges or some potential pitfalls that you can kind of see that sometimes occur when researchers want to conduct research in correctional facilities or with populations, not just people who are incarcerated, but also maybe staff, as you just mentioned, a study that were you wanting to interview healthcare providers. So what are some of those challenges, and what are your thoughts around how to address some of them?
Yeah, I'm so glad you came to me, because I wanted to ask a question that's related to this too of the others. So I'm going to do that. Well, first I'll just say, I think people are naturally cautious. I think that all of us who've done research across many areas, you see this in many types of institutions and settings. People don't know, people either may have bad history with research, they don't know what you're doing with research, they don't know what you're doing with the information. And so I think a lot of it comes down to building relationships with people, to having them know who you are, why you're there, being authentic about your purpose, and if and what kind of data you want to collect and what you'll do with that data. And I think as much transparency as possible is useful. I know one thing that I think everyone involved in Arch as a thing is really interested in is making sure that our data, our research is being linked to policy and to practice, which is something I think helps a lot. I think a lot of people have experience with researchers coming in, taking data and then taking it away and publishing it in an academic journal so that 25 people max can read it ever, then none of those are the people you've ever worked with. So I think the more we can return what we learn to the people, figure out what they want to do with it, how it's useful to them, and what kind of questions they want us to be asking, I think the better. The more we can do research in partnership, the better. But I wanted to sort of raise this question that I know something I struggle with in thinking about building these partnerships, and I'm curious how others think about it as well, is, and we talked about this actually in my mentoring session a few minutes ago, is this how people deal with the balance of sort of a belief I think many of us have that we are incarcerating too many people, that maybe we could be moving to a different system, imagining a more abolitionist or closer to abolitionist future, with the need to improve the care and the lives of people who are currently inside. So this is something that when I talk with community partners, they're very skeptical about what my role is. Am I doing work that's sort of supporting the institution? Am I extending the institution in some way? Am I extending the project of prisons by making more care there? or am I working to dismantle it? And I'm curious how folks sort of approach those types of questions in their research, both on the correction side, who might be very skeptical of any research that's trying to be critical, but then on the people side, who are skeptical of research that might be doing work to put more money into prisons in order to make them better. How do you sort of balance those competing interests?
So Jen has become moderator now, so I'm going to go, which is great. We're going to operate on the fly here and roll with it. So who wants to take a stab at that easy to answer question?
I would love to. Thank you, Jen, for mentioning it. This like has always been central to the work, but I feel like maybe in the context of COVID, it has just been so central because there is this urgent need to improve conditions. And we, have to be very mindful that this urgent need doesn't eclipse the need to move toward abolition. And I think, like what we've been in conversation in the lab and intellectually with partners around this issue. And I think there is tension here, but they're actually not at odds, right? Like we need to be doing both because human beings are incarcerated now, and the conditions in which they are living in, that they're exposed to, have to be improved very tangibly, urgently. And then I think, when we're doing that, when we're learning information, when we're publishing and working with partners to disseminate information relevant to the harms of incarceration, to the mechanisms of incarceration that are traumatizing people, those are the data that we then use to move toward decarceration, to abolition. So I think they're working in partnership with each other. And I think like that really is the answer to the question, but it's hard because like if you're doing more conditions work, does that mean that you're not moving, doing the abolition work? And so you have to really balance it, but they go together.
Anyone else want to comment on Jen's question?
I'll just briefly say, I think they definitely go together. I completely agree. You're not going to get abolition if you don't start to change the cultural perspective of who our patients are. And I think some of the work you're doing allows us to provide more humane treatment, which allows everyone to see people more humanely and which will ultimately lead, hopefully, to decarceration.
I think that's a great point. I think that's absolutely a topic that we need to dive into more deeply, for sure. And related to that, wanted to get everyone's thoughts around, piggyback on some of this and kind of thinking, what are the most important questions from a research perspective we should be asking? And again, there's obviously a continuum here of different areas, all the way from arrest through reentry. And there's a whole complex matrix of things that we could do or need to be doing. But what are some central questions that you all feel really need to be front and center in the minds of researchers? And Fernando, I'd like to start with you, just from your perspective and what your experiences can inform, the researchers on in this group. What do you want researchers to focus more on? What should be their most important questions that will have the biggest impact here?
Yeah. How can we improve public safety by so I'm going to piggyback on what Jennifer said, because this ties into what we're talking about right here. How can we I'm sorry. So how can we begin to start the process of reintegrating somebody the moment that they're incarcerated? I feel like the best way that happens is what Jennifer is talking about right now, humanizing the resident as soon as they come in, doing the research and just demonstrating to the world, changing the narrative about the needs of what needs to happen with us, so we can start the process of reintegration from the moment somebody starts their incarceration, by introducing them to a healthier way of living in the carceral setting. So when it comes to the aging and research, it won't even happen. The process is just somebody reintegrating back into the community, because we're welcoming them back the moment that they come in. And the way that happens is that we're introducing them to a better environment in which they're not subjected to these dehumanizing, ultra predatory environments that is not successful. I've never seen somebody get better in a cage. I've never seen anybody improve in a cage. It just hasn't worked. It doesn't work. And if it did, we'd be the healthiest country in the world with no crime, and that's not happening. So I think the moment that incarceration happened, that is when we start the process of trying to reintegrate someone back into the community. And I think from a healthcare perspective, that's what we're doing. That's what the researcher needs to demonstrate to the public, the data that this is successful once we start this. And I hope that there could be some research done in respect to like somebody actually creating a model for us to actually, take data from, to demonstrate success, because we know what the model of a failure looks like. And that's what our current normalization is. I hope that makes sense.
It does. Thank you. Michele, I want to get your perspective as a provider. What would you like to see more research on, and where do you feel like the biggest gaps are in terms of, between research and knowledge base we have now and really informing evidence-based practice, improving care, improving lives? What are sort of the areas that you would like to see more research on?
There's so many areas that need improvement. I think, it may be that I am just so interested in Bree's project, but I think that working with officers and really understanding their perspective and figuring out how we can get them trained and giving them the support, get them so that they have the tools they need to treat people humanely. If you don't know what to do with a mentally ill person who's freaking out, you hit them and make them get back in their cage. But if you have motivational interviewing skills, you have cognitive behavioral therapy skills, you have de-escalation skills, you understand what mental illness means, you're going to treat that person really differently. And I think, research working with officers and determining where their needs are and how we can give them more support is a big step in the right direction. And then I'm very interested in, the parole board. Our life sentences are so common in California. So many of our older patients have been given sentences of 7 to life or 15 to life, and they've served 30, 40 years. So how can we get medical voice heard more at the parole board? How can we get more training for parole board members so that they understand? I mean, I think they cognitively know that lifers have a much lower risk of recidivism than all the other people that we're releasing, but it still doesn't always translate into action. And how can we take that and get it into people's heads that the risk of a lifer on parole doing harm to somebody is less than 0.4%. It's very, very low. So I think research around that area would be useful as well.
And I'm going to intentionally skip the researchers in the group about what research questions to ask. So I'll do that on purpose because I want to give everybody, I want to have everybody respond to this next question just because I'm curious to hear thoughts. What is your most memorable and meaningful moment working either in a correctional setting or doing research? And I want to sort of kind of tie all this together as to why we're all in this work. And so, again, it doesn't necessarily have to be the most optimistic thing, but I just, what kind of drives you to continue doing this work, and maybe providing some context for that by describing sort of, this was like my aha moment, or this was a moment that I will always remember and that sort of continues to motivate me in this space. Since Michele, you're right in front of me here on the screen, so I'll start with you. Go ahead.
I'm really sorry. I was typing a response to the chat.
No worries. You just get the unfortunate get to start first.
What am I answering?
Oh, you're answering your most memorable moment.
Oh, my most memorable. That's so easy. So in 15 years of working at the California Medical Facility, my most memorable moment was watching Fernando Morillo walk out the front gate to his family.
Okay. Jen, you're clapping, so you go next.
Oh, that's so hard. I mean, there's so many, but I'll just say as a researcher, a moment that really touched me was I shared with a paper that I was submitting with someone whose story was heavily featured, and having them sort of cry and talk about how I got what they said and that they hoped that that would reach people. And I think as a researcher, that's sort of like the best thing you can hope for, is that you're capturing people's story well in a way that they hope will be impactful. So yeah, that's what I'll say.
Okay, thanks. Lauren.
I guess the answer to this is, as a part of my dissertation work, I did year-long ethnographic interviews with people who, only a handful of people who had been recently released from prison, and got to really got to know them in a very deep way, and saw very up close the instability that the system created. So it was this moment for me where it went sort of behind, like beyond paper, right? Like I had read about it, I knew about it, but I formed deep relationships with people who had been through the system and had been impacted so negatively by the system. And I think that, always sticks with me as a motivation for the work.
And Fernando, what sort of, obviously transitioning from being in the system and now sort of working to change it, what is sort of your most memorable
Yes.
experience in terms of the driver of getting you in where you are now, doing this work?
In California Medical Facility, I had my own youth diversion program. The very first time I seen one of my young mentorees, facilitate his first youth diversion program with community partnerships, I cried, because this kid was just so disruptive, so enraged, and I heavily invested in just letting him know that he had so much more purpose, so much more meaning in life than what he was currently doing, and how he was living in the carceral setting. And to see him mentor younger adults that were just like him was just like such a full circle moment. It just was like one of the most meaningful moments, and not just my institutional incarcerated journey, but just in life, period. Just watching him change another young adult's life by investing in that person in their time of need, when they felt the most vulnerable, was just one of the most fulfilling moments in my life. And just watching him, just watching him mold and shape another human being that will do the same thing for somebody else was invaluable. It's like something productive was just being passed on. Just that human connection of just caring for somebody and being empathetic and extending compassion, from the main line to somebody in the community, was just beautiful. It was just so fulfilling, so.
Thank you, everyone. So, you guys did such an incredible job adhering to time and not only packing in the wisdom into your 2-minute pieces. So now I'd like to open it up for questions from our panel folks. So, so if people have questions, just post them in the chat, and either myself or Sarah will kind of monitor that. And if you have a specific person you want to direct your question to, go ahead and do that. Or if it's just a general question, then I can kind of help see who wants to answer it.
Or they can just shout out if they
Or
want
they can
to,
just shout. You know what? You can also just shout out. Just unmute yourself and yell.
I don't have a question. I just want to thank everyone for sharing their insights, experiences, and highlighting really important pieces of this puzzle, and especially the conversation around kind of like how to collaborate and work with these systems while having this personal interest in decarceration and moving things that way, I think is something that I've been having almost part of most of my conversation. So hearing that come up today was just, validating, I guess. But thanks for sharing all.
kind of relates to that, I'll sort of throw out just as people think of other questions from you all as a group, and obviously, members of our larger network, but what do you think would be the most impactful for us as a network? How do we kind of leverage all of the expertise that we've got here and trying to develop both a research agenda, but a research agenda that's really going to inform and push policy? And so what are some areas that you feel would really be important for us as a network to really, excuse me, prioritize over the next year plus? Again, it could be related to any particular thing we've talked about or something we haven't talked about, but just getting your perspective as a network. We've got 200 plus members here, very diverse, eclectic group. So how can we come together to kind of move this area forward in whatever ways you think would be best? I'll just kind of go across. Lauren, do you want to be put on the spot for that one?
Sure. I might answer it with the question you skipped me on. I know Jen also wanted to address it. So,
Sorry,
but
we'll go back to that question. Sorry,
but it's okay. I think it relates though. I think part of like where my head is at, relevant to like where we should be going as the field, is really thinking about this connection between population health and incarceration, or the criminal legal system in general. And, like this idea of carceral epidemiology and how incarceration makes us all sick, right? Thinking about how what happens in prisons and jails doesn't just stay there. There's this very explicit connection between health of people who are incarcerated and their surrounding communities, population health in general. And so I think like that's a part of the mission. And I think, all of us are really bought into this idea of abolition. We understand the harms of incarceration, but most people don't and aren't. And so thinking about making that very clear connection to the impact that it has on general society, I think is a really important part of the argument.
And Jen, you sort of relatedly, you kind of had to, we'll circle back to the question I skipped you on. So, but you had I think it relates to sort of my question. So do you want to articulate sort of what you were going to say?
Oh yeah, sure. I put this in the chat, but I was just noting that I think that the question about what are the most important research questions is like the key question, and that I'm really interested in finding ways, how can we better learn from people who are living and working in prisons and jails about what they think the central needs are and the ways that they want to be engaged in research is something that's really important to me. And then one other thing I'll note that I think maybe relates to your question, maybe it doesn't, but I was just what I was thinking about is something that I know I find in terms of translating to policy and practice, something that I find really overwhelming. I don't know if other folks do, is that, and this speaks to what Lauren said earlier about, Rhode Island being, there's tons of data, but how generalizable is it? Is just the fact that this research it's so different, right? Every state and the BOP operates so differently. There's different rules, there's different laws, there's different oversight, there's different policies. And I know I find it really overwhelming to think about how does your work read to a national audience, let alone an international audience, in such different contexts. And so I'm curious if there's ways the Arch Network can help us think through or support how to engage in different jurisdictions, different states, how to translate what we learn to other places, how to work on policy across state lines. Like, are there ways that we can be learning from each other? A program or an intervention that was successful in one place, how does that translate somewhere else? I know something that feels incredibly overwhelming to me, and I've just been sort of focusing on staying in California, which is a big state with lots of prisons, but because it feels so scary. So that's something that I think about a lot.
I'm going to give Michele and Fernando a chance to also just respond to that, just the larger sort of network focus and priority areas. What your thoughts are around that? Michele, go ahead.
I don't think I have too much to add on that. I did have, well, maybe I'll let Fernando, but one of the questions was about how you all can be successful. And I'm just wondering if when you do research, if you are meeting with the facility. I know you meet with the statewide and you get permission, but are you making an effort to meet with like the individual leaders at the institution before you go into the facility? Because I think when you come up against barriers, it's really helpful to get a feel for who the leadership team is at the place where you're doing the work, so that you can kind of check in and get maybe a workaround if something's not going the way you want it to be going. I've had people come into our facility to do research and not even known they were there. And I think if they had taken the opportunity to meet the leadership team, I know I would have been much more supportive. And after they left, I'm like, oh no, they should have talked to this person. So it may be something you're already doing, but that was something that I was thinking of.
Well, thank you. And we're going to go to Fernando, but Fernando, I also got a really interesting question that's sort of related to what you were saying. And Lawrence, correct me if I'm not getting your question right, but brings up a really good question for us as a research network, but also really a diverse range of perspectives. What do you feel like people get wrong about the incarcerated experience? As researchers, we've talked a lot about during this conversation about the need to understand, and Jennifer just sort of also re-articulated that, and understanding all of these different health factors, and then understanding where to intervene, how to intervene. But where do you feel like maybe researchers need to have a better, more in-depth understanding about the overall experience of people who are going through the system? So I'm kind of curious about your thought. I thought it was a great question. I'd love to hear your thoughts about it.
Wow. I feel, wow, this is a loaded question. So
sorry, I didn't mean to look.
No, it's okay. So it's okay. So I'm going to answer this just based on like how I really feel. California, I did 24 years of prison in California. What a lot of researchers don't understand is there's not a universal environment for the prison system in California. Someone that does, time at California Medical Facility is not doing the same time in Pelican Bay. Somebody that's in Pelican Bay or in High Desert State Prison is consistently functioning with a lot of predatory activity in which their life is continually at risk every day. Every day, it just doesn't go away. Even in a cell, it's not safe. As opposed to somebody that's in California Medical Facility or CMC or San Quentin, they can program, they can work towards reclaiming their freedom. They're safe enough to process their developmental journeys. When somebody is incarcerated in Salinas Valley or New Folsom, they're consistently at war. When one war ends, another one begins. The culture there is very different. What I mean by that is there's consistent conflicts that just don't go away. So it took someone like myself 19 years to get to a place safe enough, like California Medical Facility, in which I can process my journey. I felt safe enough to look back and did enough self-reflecting in which I can even identify what happened to me. This doesn't happen to a lot of people in the correctional setting. They don't have this opportunity. Some people end up in the SHU, which is security housing units, in which they're permanently housed, and they don't have the opportunity to come to the main lines to even have an opportunity to go home. It's not even in the realm of possibilities because of what happened in their incarceration journey. I think a lot of researchers are unaware of the amount of predatory environments that people are subjected to in the California prison system. I had to become lucky enough for the point system to change, for the custody system to change, for me to even come to California Medical Facility. And when I arrived there, I was put up for transfer immediately because I was told I'm not welcome there. My kind are not welcome here. We want to put you on a bus and put you to a place that's more suitable for you because this environment is not for you. So I was followed around for 72 hours because that is how things work in there. And after the 72 hours, I was allowed to stay. Researchers I'm pretty sure I've never even heard anything like that. But someone that looks like me and of my race is not supposed to live in California Medical Facility. It's against the rules.
Thank you for that. So I know we're right about at time. I just want to thank again all of our panelists for a very rich and extremely wonderful conversation. And thank you to all of our audience members. Sarah, want to, sorry, Melissa, did you want to say something?
I think
Sorry, I'm trying to scroll across to find folks. Sorry about that. Go ahead. jump in.
Oh, no, I've been hearing such wonderful ideas, and as the program officer of this grant, it's just really exciting to hear the research agenda that you're beginning to put together. And one of the thoughts I had was that in prioritizing these agenda items, it might be helpful for you to apply these SMART goals and to keep those in mind to the framing of your questions. And so those are the goals that are specific. And so I wrote this down: simple, sensible, significant, measurable, meaningful, and motivating, achievable, agreed, attainable, relevant, reasonable, realistic, and resourced and results-based, and time-bound, and that's time-based, time-limited, time cost limited, timely, and time-sensitive. Some of these, the agenda items that I've been hearing, will require a long-range plan, as Fernando has said. These are not going to maybe happen overnight, but others can be addressed right now. All of them need to be pursued, but in terms of what are the ones, and then what is the approach for going about answering these questions. And I think that would help you all in terms of also balancing, this trade-off between abolition and preserving the care and dignity of people who are not out. And so I think, I think that I've heard a lot of great things, and that's it for now.
No, thank you, Melissa. I think that's really crucial to put in, keep in the back of our minds as we're talking about some of these really complex challenges. How do we sort of develop some, really concrete steps, measurable goals that we can all move towards? So thank you for that. And I think we have a break, but Sarah, I'm going to turn over to you to kind of give us a sort of just update, any housekeeping overview. But again, I want to just say thank you again to all of our panelists. Really, really appreciate your time. So thank you.